Sure. Adrian, can you hear us? Okay, thanks. Good morning, Prof. Ko and Adrian. Welcome to Seen Live again, 34th edition. Today is going to, the topic is actually left main and calcification. It just happened that we do have a case of left main and a bit of calcification. And actually, to coincide with the topic, is actually a sort of like trifurcation. Yeah. Anyway, my name is Aaron WONG. Today is with Chee and our fellows from Myanmar. And actually, the patients belongs to Chee, so Chee will be the main operator today. I just comment on it. And we have the husband and wife team, Gianna and Edwin, our radiographer. So without further ado, Naing, we're going to present the case for you today. Huh?
Hi, good morning. This is 52 years gentleman with previous history of stroke.
Can we have the slide, please? Yeah.
Presenting with NSTEMI in November last year. And we did get on 21st of November. And it is diffuse proximal to distal RCA disease with some haziness in the mid-RCA, likely the cover dilation for that presentation. And left main is calcified with eccentric lesions extending into the ostial LAD. Circumflex has also some disease in the proximal and distal parts. And so traversal disease with left main involvement. And the patient declined CAPG. So we did PCI on 2nd of January. His renal functions is normal, and his LV function is also normal. So we did PCI to the RCA and stented with 3538 and 3038 stents from proximal to distal RCA.
So this, what you see now on the screen is the angiogram at the diagnostic. You can see on the caudal view, a distal left main with the calcification on top, and also a very angulated LAD, some moderate disease in the circ. And what can't be seen properly is there's a branch coming in between the circ and the LAD that either a ramus or a very high diagonal. Yeah. So next slide, please. Next slide. So this is RCA, which we think was the culprit during the non-STEMI presentation, and show the final pictures after we stented. Chee did a very nice job. Very big RCA, actually. Yeah. So the circ wasn't that big, as you can see. Okay, next, yeah. So in summary, this patient had non-STEMI. We treated the culprit and found that you have distal left main and ostial LAD disease. So the target today is left main to LAD. So we need to decide whether we need to treat the circumflex. Yeah. So Chee, we go back to the case. We show the angiogram we done today, and then we can give some comment from the panel. Yeah.
Yeah. Okay. So we have today, in terms of access, we have a radial access with a 7 French glide sheath, and the guider that we have gone for is a 7 French EBU 3.5. So this is the angiogram from today. So on the left, the areocaudal, on the right, the iliocranial, and you can see that the distal left main tapers down. Not sure if it's clear in the auditorium, but there is a chunk of calcium, at least angiographically it's obvious, just at the superior part of the distal left main. This is the areocranial and the spider shots. So the rest of the LAD, so the disease extends to a bit into the proximal LAD, but the rest of the LAD looks quite healthy and disease-free. The spider view on the right, not very helpful because it doesn't show the bifurcation / trifurcation very well. And perhaps just finally show you the AP caudal view. So in the AP caudal view, you can see that the LAD takeoff is quite acute. Seems to go from the left main goes up and then back down again. So we anticipated some difficulty wiring that part. But yeah, so this is what we are faced with today. This distal left main eccentrically calcified lesion. And our plan anyway is to provisionally address this from left main to LED. But we're happy to hear any comments that the panel might have.
Yes, initially when we look at the case, the osteo cert doesn't look like there is a disease, but the distal cert, there is some moderate disease. So we decide that is a vessel not very big. We decide to medically treat the cert. Unfortunately, the origin of the ramus is not very clear. In this field, maybe just below the LAD. We plan to stand across left main to LED provision, and then maybe at least do a case with the circ. If can, via the third branch, we can do a triple case. So that's why we use a 7 French guiding this time. Yeah, I'd like to hear some opinion from the panel. Yeah. Yes, so in this case, what sort of imaging would you be using? IVUS or OCT? Any preference, the panelists? Obviously, we selected one our imaging strategy already. Adrian and Prof. Ko, but I think
Starting to turn it up. Increase the volume. Increase the volume.
Louder?
Okay, I think, yeah, so I think we'll show you what we did. Yeah, so we had that little debate about IVUS versus OCT. Let's show one. But we went for OCT. So I hear the comments about and the concerns about OCT in the left main, but as you can see, this left main is quite long, and the disease is in the distal part. So there really shouldn't be any issues with getting a good OCT image here. Let's get the OCT up. Yep. The main concern was whether or not the OCT could navigate that that acute angulation. I'll just show you. Yeah, so this is our wiring of the LED, just to show you that it was just a little bit challenging, not too bad. Managed to get it through and then down. And the OCT catheter actually went down quite easily. Of course, OCT does have that added benefit of being able to quantify the amount of calcification. over IVUS, which is more of a qualitative assessment, although there is an IVUS calcium score. So anyway, so we went for OCT, and we'll show you the OCT pullback from the for the pre-PCI assessment. Okay, so this is the Ultron system that we have and we've recently started to use. Can we not change that? Can we show the OCT, please?
Ram, change
Yep.
it to the.
Okay. All right. So you should be able to see OCT nice and big now. So here we are in the proximal part of the left main. We have two wires. We wired the circumflex as well. So we have two wires at the moment in the proximal part of the left main. Left main is huge, and the artificial intelligence or the automated calculations tell us that the vessel size here is about. Let's go back to where it can measure. Yeah, it's about 4.8 to 5 millimeters in diameter. So it's a large left main. As we go more distally, we'll see that the left main starts to taper. There's the beginning of some disease there in the 5 to about 9 o'clock position. It doesn't look immediately obvious that it's calcification. There does seem to be a rather thick layer of fibrous tissue anyway between the lumen and whatever calcium there may be. So on OCT anyway, in this particular image, it's not very clear that there's a lot of calcium in the left main. Here at the 4 to 6 o'clock region, we start to see maybe a hint of some calcification. And as we go more distal, we start to see a little bit more calcium, like in the 10 o'clock and the 2 o'clock position. But we don't see the very kind of thick calcification image that we are usually concerned about. All right, here is at the just at the distal left main. So now we start to see a little bit more calcium, yeah. So in the 3 to 4 o'clock, we can see a big chunk of calcium there, and the 9 o'clock position as well. I suspect it's all around, just that we can't quite see it obviously. There is, as I said, a bit of a fibrous tissue between the lumen and the calcium, and that has implications, because if we are going for an atherectomy strategy, then it might not be so effective to ablate if there's a layer of fibrous tissue between the lumen and the calcium. So that was the circ. Now we're in the LAD, and that third branch that we were wondering whether it was a ramus is probably a high diagonal. There it is going off in the 12 to 1 o'clock position. This is the proximal LAD. Again, not a lot of calcium here, and mostly fibrous tissue, and maybe some thin calcification on OCT. So yeah, so mostly, so there is calcium on the OCT. It looks like a short segment. It doesn't look particularly thick in most of the segments. So yeah. Hi, Sydney. How are you? Yes, we are. Sure. Yeah, like here. Yep, that's right. So on this particular pullback, there's only one segment where there's orange, which is this one. And when you actually look at it, it doesn't, whatever calcium that it's indicating is at most, some thin or scattered kind of calcification, not the big chunky calcium that we are usually worried about. Okay, so based on that, on the OCT findings, we decided not to go with an atherectomy strategy. We elected to go with a balloon strategy up front. Would anyone differ in their opinion? Yep. Yeah, it's good good point. So the things that we would want to look out for would be the carina tip angle, looking for the so-called eyebrow sign and all that. I'll be honest and say we did not spend too much time doing that. We did do a pullback from the circumflex as well. And the ostium of the circumflex was relatively disease-free and was about 5 millimeters square in area. So we were not going to address the circumflex with an upfront two-stent strategy.
Okay, so change back to angio. So actually, we plan to just based on balloon base treatment. So we just use an NC balloon. Actually, while we're waiting after the OCT, the blood pressure sort of plunged a little bit. Maybe the wire actually straightened the vessels, causes some intersection. So straightening the artery, so causes some ischemia. So we sort of pre-dilate with 2.5 and balloon. As you can see, the calcium is quite thick actually.
Yeah.
Yeah. And then we upsize it to 3.5. The next one.
So this is a 3.5 NC.
This is higher pressure, 3.5 NC. So next view. Back one. Yeah, as you can see from this view, Xian just mentioned now, the wire is straight, but the artery is turning up and down. See, so the wire is actually cutting into the vessel. So to do rotablation, atherectomy, in this case, I think the risk of perforation is super high. So I'm not sure what the opinion of the panel. Yeah. Open the stent. Open. Open the stent.
I think it's always difficult, especially in this case. As Aaron just mentioned, although it's naturally angulated, we have already straightened we artificially straightened the wire, the artery with the wire. So the OCT is going to follow that path. So it will be difficult to know, but certainly that's a concern of ours as well. So we are cognizant of the transmission time, so we are going to crack on. So we did the measurements on the OCT, and we've decided on a 3.5 by 28 millimeter Zion Sierra stent. The patient also is a bit restless, so we don't want to spend too much time. Yep. Yes.
Yes, we can show it to you later on. Yeah, after we.
Yes.
Yeah. Okay. Yeah. So this is 3.528. So we sort of measure. This is what we wanted it actually, right?
Yeah.
Okay. All right.
Sini?
Okay. Sini, yeah. Maybe go in just slightly. Okay. Yeah. Sini. One more time. Okay. 12. Yeah. Give me a 5-0. Pop. Okay. 8 better.
You're gonna pot first.
8, huh? Cordo.
You're gonna pot first.
Pop first, definitely. Stem boost. Stem boost.
Can we stem boost?
Stem boost. Stem.
Is it ready? Are you can you collimate?
Okay. Okay, huh?
Yep.
So we have a 4O dilated thing now. Top.
Yep. So there is some.
How come it doesn't show up there? Oh, okay. Stem boost again. Okay, come back.
Yep.
Okay. 12. 4O. 4O. Okay.
12 is fine, or 15 also can.
4O.
Oh, 12.
Can we show the stem boost here? We ask him to show the stem boost and then expand the stem. Okay. No, don't float. Can save this one. Sorry, just to stop the discussion. Can you see the stem boost picture? Yeah. So obviously there is a quite bad calcification. This is really quite outside the wall. And even rotablation may have difficulties getting this calcium. And also looks like very eccentric. So IVL may or may not work in this situation. So we pot it with 5O, and this one is a 4O balloon, NC balloon 12. So we can see whether we can just try to open out this 24. Yeah. Okay. So there is still a waste there. Can we just do a stem boost, see whether it expands better? Yeah. Yeah, it's slightly better. Yeah. So I'm not sure whether doing IVL rotablation will achieve a perfect result in this case also. So with this sort of eccentric calcification, sometimes we just have to accept sort of not an optimal
Do you want to go anymore?
optimal stent expansion. Yeah. Okay, we need 4O to dilate the proximal to nominal 12 and 14. Okay, down. One more dilatation at the bifurcation, higher pressure. Okay, yeah, okay. 24. Okay, we do one more stem boost and then. In this case, anyone who have done anything differently, or it's too late to do anything differently? Yeah. 3-5. 3-5.
Is that a 3-5?
Yeah, 3-5. We're going to use a 3-5 NC.
So the aerial cranial.
Distal part. And after this, we're going to do a OCT. Make sure that the stent is expanded, and then we will recross a circ and then do a kiss, maybe a triple. Yeah. See.
We did Yeah.
We
so
did a 4
we did
all.
no, we did 5 in the proximal.
4 at the ostium. Sorry, of the left main. Yeah. But we didn't cross the carina door. Same boost, yeah.
Just, yeah.
We can use a short 4.5, yeah. Chiang will answer this one.
I don't think so. I think the key measurements or the key information that we derived from imaging here,
16A.
I can't think of anything extra we would have gotten from IVUS in this case. Oh, sorry, you want more?
OCT.
Open up. Live. Enable.
So we're doing the post dilatation OCT. The flow in the circ looks good. Not sure whether the ostium is compromised, but not caudal view. So anyone would just leave it like this if the ostium not compromised, or would people routinely do KISS for the circ? It's a small circ anyway. Yeah.
Okay, so we can look at the OCT now. There's some, so we need to, yeah. It's the malapposition.
Oh, what?
Just the proximal edge is malopposed, so we need to go back in with the 5 later. Yeah.
We missed it lah.
Either we missed it or on pulling back it.
Okay.
Yeah. Okay, so this is, so we're going to assess the stent. This is in the left main. We're going from proximal to distal. So here we see that there are some stent struts which are hanging in the lumen. So either we missed the proximal edge of the stent when we were doing our pot, or
5-4.
quite likely also when I was pulling the big balloons and the OCT out, the guider may have got sucked in and disrupted the proximal edge. So
Negative.
yeah, so we'll go back in with the 5.0 to redilate that part.
Explain
So
the thing.
okay,
Yep, sure.
yep. So the rest of the vessel's okay. So this is the distal edge. Distal edge looks
Oh.
decent to me. The flushing is not great down here. Yeah. But I don't see any dissections or hematoma, so I'm gonna accept that. We can see now that we have dilated or stented the lesion. There seems to be
Caudal, please.
some under expansion here in the distal part of the left main. not not surprising, I guess, because there was the eccentric calcification that limited or hindered our balloon full balloon expansion. It's a rather ugly number of 52% according to the AI.
Can we get a new 5.0, please? Yeah. So they have a bit of difficulties going in. The thing maybe is
eight preferably. Yeah.
okay. Can. So, right.
Stem boost.
Okay, ready? Con in. It's quite far away from the stem here. Ready? Can we change to stem boost? Yeah. Okay. Yeah, it's a bit deformed here. Yeah, correct. Yeah. Can we use a new balloon, please? 5.0. Yeah, it's always a risk to put the side branch wire.
Yeah,
There's
you get
always that
trapped,
part that may have get lifted up, but sometimes we need the side branch wire to protect the side branch. Yeah. So 5.0, short one. Yeah. Come, let me have the 5.0 short one. Okay, can. Only one set. Okay. Okay, so the rest of the stand is okay? Or?
Yeah, so the distal in the distal left main there's a bit of under expansion, but as we discussed earlier, I don't think there's much more that we can do about that. Having been the operator for most of the case, I would say yes.
Okay.
Anyway, the balloon, the new balloon
cross easily.
goes easily. We'll do a boost.
Can we see more stand? Okay, here. I can go in a little bit more.
Okay.
Okay, here. Yeah. This is 8. 10, 12. Okay, boost again. Yeah, much better now.
Looks better on the stand boost.
Okay, one more time.
Yeah.
And then we go in a little bit. 12. Inside, yeah. And then we're going to repeat the OCT.
Okay, here.
Yeah. This is where the carina is. Yeah. So the side branch actually gives a very good idea where the carina to be. So it's
Just let the balloon come
so
down.
you think Sydney is useful to use a 4.5 to dilate that under expanded part? You think it will help?
Give me a cranial view, please. I need to move the wire.
Yeah. Okay, should be all right. Okay. So we're going to repeat the OCT again.
Okay, I got it. Okay. Okay, enable. Okay, just try not to repeat the mistake. Okay, so we're going to have to look at the OCT again. So back to the proximal stent edge. So we can see that the proximal edge is all well opposed now. So no more struts hanging around in the lumen. So that's good. And no dissection in the proximal edge.
Edwin, Cordo. Cordo.
Yeah. So this is the distal left main. There is some under expansion here due to the eccentric calcification. But we already went up with a 4.0 at high pressure, so I'm not sure what we're going to be able to achieve much more there. The rest of the stent and the LAD looks pretty decent. And no distal edge issues. So I think Aaron's going to try and, or one of us is going to try and...
So I think it's a young patient, so...
new wire or same wire?
Can we use the new wire, please? Yeah.
Xiong
So
blue?
we think we're going
Xiong
to
blue?
just wire the circ, do a kiss. I'm not sure any objection to this, that just in case that that came back with restenosis in the future, then it's easier to wire the circ. Yeah.
Introduce her.
Hopefully she would never come back, but I think if it's not difficult to do a case, I think it's fine. There's no added extra too much time and the risk, then I think it's worth to do a case. Yeah. So I think the LAD and the left main we sort of sort out, and it's very important to make sure that the left main stent is fully expanded, because wiring this may accidentally go under the stent strut if it's not fully expanded. Okay, we haven't. Have we done a shot? We haven't done the cine yet, actually. Do we?
No, we haven't.
We haven't
You
done
can
the
do
cine.
one.
No, we'll do a cine for you here. Okay. Yeah. So it appears there's a line across it, but I think this is the interface of the vessel wall. I don't think it's implied that it's the nose actually compromised. Yeah. Tends to go to the
OM.
I think it's okay. It's
Take
okay.
it, huh?
It's okay. There's no lesion there, Sydney. So I don't think DCB will be helpful in this case. Yeah. 2-0.
We don't have to. No.
2-0 balloon.
Lights.
The 2-5 and 4-0.
We have got 2.5. We already have a 2.5.
Sorry?
We have a 2.5.
Oh, yeah, correct.
This is 2.5.
2-0. 2-0 first. 2-5 minutes. Okay. Yeah, that's what we're using, 2O balloon. Firstly, we have a 2.5, but it may be too big for the cert. 14. And then we use a 4O. Yeah.
Keep it there. Huh?
Take out the other wire now. Careful. So when you take out the other wire, have to be very careful. Make sure that the guide doesn't jump in here. Yeah. Negative for me. Okay, just to answer that, I think this is a 2O balloon. So 2O balloon usually do not causes a distortion of the opposite side. If you use a very big balloon like 3O, 2.5, or then the chances of pulling the stem back on the opposite end is high. And secondly, we're going to do a kiss. So with a 4O balloon in a LAD, and it's unlikely that part will be lifted. If you do a final kissing, that it should avoid that. Should have avoided that scenario, lah. Yeah, come give it a kiss. More. That's good. Ready? Set. Sure. 12, 14, 16, 18, 20. See me? Okay. Take out this one. Boost with that.
You want to boost with
Take
the
out this one.
boost?
Yeah, but I think because there is a certain size of the stent straps area, so to be honest, if you use a bigger balloon, when we do a sort of on the model, it's more likely to get distortion as compared to a smaller balloon. Yeah, so I think 2O balloon in this case should be fine. Stem boost, we have seen the stem boost picture. Yeah, so it's not. Yeah. This is before, right? This is after. This is exactly, yeah. Yeah. This is this one, yeah. This is before, eh? Yeah.
Pot.
Huh?
See one.
Yeah, no, I think we got time. 5-4. Negative.
Okay.
Take out the other wire.
Am I true then?
Okay, stand boost.
Y-
12, 12. Yeah.
Okay.
All right, so we've done the case and plot it again with the left main. So we're going to do the final picture here. Okay, remove the wire. Can we have epicaudal? Yeah, both caudal, and then one print.
Yeah, we're taking that now. So we can show both angios
both
side by
angio-
side.
No, because
no, not-
we didn't
yeah.
touch the LED, it's on the left main, so we plot it again. Yeah.
Do a aerial. Yeah.
So obviously, angiographically not so satisfying in this field, but I think I'm just thinking what other things that we could have done to make this the expansion better. I'm not so sure whether IVL, atherectomy. It's very eccentric, this view, looks like the expansion is quite well on this cranial view. It's only the caudal view that so the eccentric calcium is
Yeah,
especially difficult
remains.
to treat. Yeah.
Yeah, remains a problem.
Yeah, a DCA for calcified lesion is I think it's contraindicated. Yeah, maybe orbital. Yeah. Okay, so we have finished the case. Any other comments or question for this case? Yeah. Yeah. Yeah, correct. OCT run. Yeah. OCT run. We haven't shown the
okay.
one, the post-dilatation one, right? Yeah, pre-stent. Yeah, pre-stent.
Pull back one.
One more. Number
So
three.
I'll need to go to the computer.
Number three. Number three. Pull back number three.
No. Number one.
Number one. Okay.
Can you show how to? Can you change the threshold for the orange? Yeah. Okay. So you can see the screen. Yeah. Hello. Yeah. Okay. So this is the initial pullback. So as Sydney was mentioning earlier, if the AI detects calcium, it will indicate it with an orange arc like this, and if the arc total arc is more than 180 degrees, which is the preset, then it will show up down here on the longitudinal view as well. So you can see on the longitudinal view, that only one frame seems to have the 180 degree calcium arc. The rest of it, although calcium is seen, does not reach the 180 degree threshold. But we can change this threshold. If you just go to this tab here on the right, you can see that the threshold down here is by default set at 180 degrees. We can always change that to less or more. And when it falls, when the arc is above the threshold, you can see it changes to an orange color, and then it shows up here on the longitudinal view as well. Okay, we'll go to 90. Yep. Yeah, so obviously the lower we drop the threshold, the more yeah, exactly. Okay, but I mean, if the default is set at 180, I guess because the calcium scoring system uses 180 degrees as the cutoff. But you can always play around with it. Yeah, I suspect that there is a thick chunk of calcium here in the 3 to 9 o'clock region, just that we can't quite see it.
270. Two.
That much more clarity to your calcification assessment. It is tough on IVUS because you see nothing behind it. It's all black and it's very, very difficult to see just white blobs and think, what does that mean? You're not quite sure what it means except 270 or above. So I think OCT is very superior in this setting when it's a distal left main bifurcation, not ostial. And you can see it very quickly read. It's very useful on the workflow. It's very useful on the accuracy, and I think automated is great for workflow.
But now the IVUS also has the automated workflow, right?
It's getting there, and the interfaces are very similar, which I think it's a good thing, because when they introduced Ultrasound 1.0, the whole thing reversed everything on all the users, so we were very unhappy.
Dr. Jones?
I'd be interested in the panel's opinion. So we run 6 labs. Do you have OCT like this in every lab? My bias is the amount of money that we have to pay for this integrated system, it should deliver the stents for us. It should do everything.
Adrian.
I heard a funny story. The funny story was users paid for the upgrade to Ultrasound 1.0, and so company removed AptiView, and then they were unhappy with it, said, can we have it back? They said, be charged to remove the Ultrasound, charged to replace the AptiView. I said, that's not great.
Great. I think that was an excellent demonstration, Aaron and Chee. Yeah. So I think we've all learned very much from this case here, and you've demonstrated very well the challenges with left main calcification and what are the options that we should consider, and also the value of intravascular imaging. In particular, OCT can be used in left main intervention in the appropriate patient. Like in this case here, when there's a good long left main, that you can have excellent clearance of contrast. So those were beautiful OCT images. And we've also learned the understanding of the various thresholds and how that can affect the computer's interpretation of amount of calcification. So I think everyone in the audience have, as well as the panelists, have learned much from your case, and maybe I'll just pass to Prof. Koh for the final words before we close this session.
Yeah, maybe just Aaron or Chee, you have any last words before we close?
No, I think we are pleased with how the case went. It was good that we were able to just do a provisional left main to LAD rather than a complex two-stent strategy. And I think part of that was the confidence that the imaging gave us. So So yeah, I think it cannot be stressed enough that imaging improves outcomes, especially in complex cases like left main, like calcification. I'm glad we managed to get as good or as decent a result as we could have hoped for.
Yeah, just one last word. Yeah, perfection is the enemy of good. So I think with this sort of result, I think it's acceptable. So if you want to have a perfect result, you use a bigger balloon OPN, may eventually end up with a perforation and some complications. So I think as long as the lumen size is adequate, I think this sort of imperfect results is sort of acceptable. I don't think there's any other method that actually can achieve a full lumen expansion in this case for very eccentric calcium, thick calcium. Yeah.
What about the criteria for optimal stent expansion for left main? What do you think in this case? You got about 8 something, right?
In this case, it's a bit tricky to apply those criteria. It was just a single. Can you select the final one? It's just a single stent rather than a bifurcation stenting. The final one. So I think we have to go, and also because of the distal calcification, which hindered our expansion a bit. But nonetheless, if we look at the numbers here, it's still about 8 to 9 millimeters square. I think we accept that.
I guess to comment on those are sort of minimum numbers, and then and also is the risk of achieving it. Like say OPNs, when you say OPN, I don't personally like OPN balloons, so I avoid them generically, just avoid them altogether. Because all you get is, if you're trying to expand it aggressively, all you get is rupture. And I think that's not really a great equation. We're trying for a few millimeters of a stent area. In any case, those things are kind of what you can achieve safely, and they've achieved an excellent result. Angiographically, I think we should ignore. I think we learn for those more imaging you do, the more trust there is in the imaging. Don't look at the angiogram that much. That's all good. Look, it looks so fantastic in the other views, very eccentric, and the area you've achieved is excellent. So I think that's a reassuring thing. That is just an amazingly good result. It illustrated many different things in the case, which I think was very illustrative.
Thank you. I think very good teaching points from Sydney. So Aaron and Chee and Dr. Yang, thank you all very much for this very nice demonstration of left main stenting. Thank you.
Thank you.
Thank
Enjoy
you.
the meeting.
So.